I'd like to introduce at this time Dr. Gaurava Agarwal, who is Associate Professor. You can read his bio in your handouts. He's the Associate Professor in both the Departments of Medical Education and Psychiatry and Behavioral Sciences at Northwestern University's Feinberg School of Medicine. I'll just highlight a few of the many things that he has done in a very young life. He serves as the Director of Physician Wellbeing for Northwestern Medical Group and the Director of Medical Student Education and Psychiatry at Northwestern's Feinberg School of Medicine. He has won many awards and been recognized as a premier educator many times. Among them is that he's the first psychiatrist to win the George Jost Award for Outstanding Clinical Teacher from Northwestern's Feinberg School of Medicine. He serves as a well-being consultant to multiple national organizations and is a certified leadership, organizational, and well-being coach. Dr. Agarwal specializes in occupational and organizational psychiatry with an emphasis on mental health in organizations. He is an amazing human being. He created the Scholars of Wellness, a 2019 Illinois Psychiatric Society innovation, and was given an award for that, designed to help address the organizational drivers of physician burnout. He is an amazing human, as I said, and he is going to be moderating a panel today, and I'm going to turn it over to Dr. Agarwal at this point. Thank you.
Thank you so much, Tim. That was very, very kind. It's a privilege to facilitate this discussion today with our esteemed panelists. To set the stage for our session, I did want to present a framework that illustrates how the multiple challenges we heard about yesterday have impacted clinician well-being work at the organizational level. If we take an occupational health prevention perspective, there are 3 levels of prevention that are used to minimize the risk to health: primary, secondary, and tertiary prevention. Primary prevention aims to prevent disease or injury before it ever occurs. This is done by preventing exposures to hazards that cause disease or injury, or increasing resistance to disease or injury should exposure occur. This is where I spent almost all of my time pre-pandemic attempting to optimize the balance of work demands and resources that Professor Carrion spoke about yesterday, so clinicians could achieve professional fulfillment and reduce burnout. However, the pandemic has forced me to broaden my focus to secondary and tertiary prevention strategies as well. This is because we needed to respond to the type of data Dr. Sinsky and Dr. Malone presented yesterday, along with simply listening to the requests and needs of our colleagues on the front line. Secondary prevention aims to reduce the impact of a disease or injury that's already occurred. This is done by detecting and treating disease or injury as soon as possible to halt or slow its progress. We know that levels of distress due to the various stressors we all face right now are very elevated, and we need to respond to that distress aggressively and urgently to minimize progression to illness and impairment. We also had to focus on tertiary prevention, which aims to rehabilitate and treat illnesses to reduce any long-term impact of disease and improve quality of life. Data from both past pandemics and the current crisis are clear that there will be some level of elevated disease in our frontline workers, and they deserve high quality, readily accessible healthcare to help them recover as quickly as possible. Next slide, please. Our session today will help us understand how this comprehensive 3-level occupational health prevention model interacts with the 3 levels of the systems model of clinician well-being. My hope is that it will highlight how the 3 system levels must interact to be able to facilitate optimal outcomes for our clinicians. For example, with increasing distress symptoms in our clinicians, it will be necessary for individual clinicians to make sure that they recognize their symptoms and seek help if and when they need. It will also be necessary for care team members to look out for each other and encourage help seeking if they notice a peer struggling, which can help end the culture of suffering and silence. It will be incumbent on organizations to provide a broad spectrum of resources, such as the ones that Dr. Farley shared with us yesterday, including EAP access, peer support programs, digital mental health options, and high-quality health insurance for clinicians to utilize should they need. While all of that will be necessary, In my view, it is unlikely to be sufficient in our desire to provide support to everyone if we cannot also mobilize the external environment to clarify the regulatory environment that permits clinicians to seek help in a non-punitive manner that protects their livelihoods. My hope is that a silver lining of this pandemic can be that it presents an opportunity to accelerate the progress that has been made in this area as the urgency to act is clear. With that, I look forward to our panelists' presentations who will discuss their roles in mobilizing this needed external environment response. Our first panelist is Dr. Elinore McCance-Katz. She is the first Assistant Secretary for Mental Health and Substance Use at SAMHSA. She obtained her PhD from Yale University with a specialty in infectious disease epidemiology and is board certified in general psychiatry and in addiction psychiatry. Thank you.
Thanks very much for the invitation to speak to you today about what I think is really a very important topic, and that is the topic of healthcare practitioner, mental health and wellness, and the impacts of the pandemic on mental health and wellness in our healthcare professionals. Can I have the next slide? So I want to start by talking about burnout in healthcare practitioners, because this is a topic that has been talked about for many years and affects a large number of healthcare practitioners and was doing so long before we ever saw COVID-19. So burnout is an area that is researched by a number of different investigators who have described it as a complex syndrome of emotional distress due to occupational requirements. It's characterized by feelings of fatigue, increased cynicism, and feelings of decreased self-efficacy. People often will develop depersonalization. For example, they may start to think of their patients as diagnoses rather than as people. Burnout results from high levels of emotional distress, exhaustion that are related to what's required of us in the context of our healthcare practice. And it also can be associated with people having a feeling of just low levels of personal accomplishment. And that can lead to people questioning their judgment, their decisions, both in their professional activities, but also in their personal lives. And as I said, there's research going on in this area. Back in 2014, over 54% of physicians reported at least one symptom of burnout. That's a pretty substantial increase from 45% in 2011. And it's not restricted to physicians. Non-physician providers, nearly a third of them report symptoms of burnout, and 27% of support staff. Can I have the next slide? And healthcare practitioners have experienced all of the adverse life impacts that all Americans have had to endure as a result of the pandemic. The anxiety, the depression, the grief, the isolation that all have experienced as a result of the virus and actions we've taken to try to control the spread of the virus. Healthcare practitioners certainly have not been immune to those effects. But in addition to that, healthcare providers are subject to a whole variety of other stresses. For many, they've had to take care of increased numbers of critically ill patients, sometimes without appropriate training. And the feelings of helplessness and frustration are great for people who have been asked to do things that they may not feel prepared to do for large numbers of people who are critically ill. For many, many thousands of healthcare providers, there's been an inability to serve their patients. There are patients who have many different conditions, general medical conditions, mental health conditions, substance use disorders. Facilities have closed, and people have experienced healthcare practitioners out of work. In fact, we saw a survey from mental health facilities and substance use disorder facilities. Nearly half of them have laid off or are planning to lay off healthcare workers in those settings because of the restrictions of COVID-19. And in addition, despite the fact that the workload has increased so much, we haven't been able to streamline things like billing and other administrative tasks that I think all of us could agree are not a great use of healthcare practitioner time and are very, very frustrating during these kinds of situations. There's a lack of support for and payment for patient services, inadequate staffing often, a lack of payment for services such as care coordination, which are so important to people with illnesses like COVID-19 that are going to require a lot of different types of services for their full recovery. For many, particularly early on, the lack of personal protective equipment, the lack of access to testing, and in some areas, we know that these shortages and these inability to rapidly access resources continue. People fear illness, they fear transmitting it to people they care about, and many thousands of healthcare practitioners have passed away as a result of the virus. All of us are so aware of that. And this is extremely stressful for healthcare practitioners. And there's also, for many, the stigma of difficult choices. For some people who must make a decision about their personal and family safety versus what they know to be patient needs. This is very stigmatizing. And it is, I think, a source of great guilt for some practitioners. So these are all effects of COVID-19 that are being experienced within the context of what we know to be a big problem with burnout amongst our colleagues in the healthcare professions. Can I have the next slide? And so SAMHSA did take action early on. I don't know how many people are aware of this, but we did take action early on. My own background, I spent a number of years running the Impaired Health Professionals program in the state of Virginia. And so I'm very familiar with these kinds of issues, and I think they're very important issues. And so when we received from Congress $110 million in the CARES Act to assist states, tribes, and territories in addressing their mental health needs related to COVID, we are given pretty broad language in the statute, and then we decide as an agency where to place those funds. We required that 10% of that funding be used to provide mental health services to healthcare practitioners who were impacted by COVID-19. We worked very hard to get this money out because of the great need. We awarded it in April of 2020. As you know, the CARES Act was passed around the end of March of 2020. For those of you who aren't familiar with our process and the process of federal agencies, generally funding announcements are out for about 2 months, and then we spend several months reviewing and determining who's going to get the awards. We did this in 1 month, and we did it because of the great need. We then follow up. Our process at SAMHSA is to award these funds and then to follow up regularly with our grantees to determine if the funds are being used for what we intended and are we getting the outcomes we intended to see. And in September, I was informed by my staff that the field was not making use of the mental health funds that we had put forward in the CARES Act. And why were they not doing this? Because healthcare practitioners were concerned that making use of these funds or mental health services would be reportable to their licensing boards and would stigmatize them. And so what we did at that point was we changed the use of the funds to that of support services only to assure practitioners that they would not be reported to their boards should be for taking part in or making use of these resources. Can I have the next slide? And so I think it's important to talk about institutional stigma and what the role of licensing boards is in institutional stigma. For many medical and other healthcare professional licensing boards, they undermine the mental health of healthcare practitioners through discriminatory and intrusive questions about mental health and mental illness. These can prevent practitioners from seeking help. Probably those of you listening, you probably all know of situations in which practitioners have gone to very great lengths, sometimes leaving a state and getting help in another state to try to prevent their colleagues, the community, from knowing they have a mental health condition and getting help outside of that risk of being reported to their board. This can result in more severe illness. It can have personal and professional consequences. It can be potentially associated with death. And suicide has been called an occupational hazard of the medical profession. Medical students 3 times more likely than their peers to kill themselves. Up to 75% of interns meet criteria for major depression at some point during their internship. Suicide risk increases with untreated mental illness. And in addition, untreated mental illness may result in practitioners self-medicating. And there are other risks with self-medicating that include things like developing substance use disorders, as well as violating laws around diversion. So these are very serious kinds of consequences for not being able to get assistance when needed. And doctors have the highest suicide rate of any profession, by the way, including people who serve in the armed forces. So the effects of COVID-19, what can we expect? We can expect that these issues will be exacerbated. People who had mental health conditions prior to COVID-19 and were serving in a healthcare field may see a worsening of their condition. And for many healthcare practitioners, the stresses and the strains of COVID-19 will probably be the basis of them developing a mental health condition. Can I have the next slide? And so what are the solutions? What's a good way to move forward in addressing mental disorders in healthcare practitioners? I think the first thing we need to recognize and acknowledge is that licensing boards have an obligation to protect the public. This is the reason they exist, to protect the public. And all 50 states have licensing, and the District of Columbia have licensing boards that work very hard to protect the public. But I believe that monitoring and competency assessment should be reserved for those practitioners who have shown that they are unsafe to practice in their field. And so showing impairment in the workplace would be a reason to have a board know about a person's mental health condition. I think that a question on the licensing application would more appropriately be, are you currently experiencing any condition for which you are not being appropriately treated that impairs your judgment or would otherwise adversely affect your ability to practice medicine in a competent and professional manner? If the answer to that question is no, because you may have a history of a mental health disorder, of a mental illness, but you have not been impaired in the workplace, you should have a right to confidentiality and privacy. So short of impairment in the workplace due to a mental disorder, I would ask that licensing boards not ask questions about mental health. And certainly they should not group mental health with questions about substance misuse and sexual disorders, which happens on some licensing applications. It's very stigmatizing. If a practitioner has had impairment in the workplace because of a mental illness, then they should be referred to a monitoring program, and they should be able, again, to keep their confidentiality so long as they work within the monitoring program. Can I have the next slide? And I also want to talk about what we can do at SAMHSA, a federal agency, what we can do to help with this situation. I'm very pleased to be able to tell you today that SAMHSA is awarding funding to specifically address healthcare practitioner health and wellness. We are doing this through supplements to our mental health technology transfer centers. There is one in each of the 10 regions that HHS divides the country into. We are putting $2 million into this, and these programs will make training and technical assistance available on health practitioner wellness. There will be activities for healthcare practitioners to participate in that will address wellness, mental health issues, how coping with death and dying, for example, taking care of yourself at and outside of work. These kinds of important aspects of our professional lives and our personal lives will be addressed by these technology transfer centers. We will also make technical assistance available to healthcare organizations so that they can offer ongoing wellness activities for clinicians that work in their systems. We think that's a very important component of healthcare practitioner wellness, and we want to do everything we can do to make sure that healthcare practitioners are getting needs addressed in terms of mental health and wellness. Next slide. It's really very important because there are so many benefits to be had from these activities. Improved mental health of our healthcare practitioners leads to greater satisfaction in the workplace, less burnout, and it will ultimately bring more people into our healthcare professions, which we very much need. We very much need in the United States. And in doing that, it will increase healthcare provider access to Americans who need the services that you all provide. Next slide. So I want to just end by thanking the National Academies of Science, Engineering, and Medicine for bringing attention to this really very important issue. To our healthcare practitioners, really for what has been your just tremendous service and self-sacrifice in these very, very difficult times. And to everyone who's listening, for your consideration of the importance of mental health conditions and your work in reducing stigma in this area. Thank you very much.
Thank you, Dr. McCance. I've been a beneficiary of the toolkits and guides that SAMHSA has been put out, and so very appreciative of the resources you've provided. Our next speaker today is going to be Dr. Humayun Chaudhry, who's the President and Chief Executive Officer of the Federation of State Medical Boards. The FSMB represents all the state medical licensing boards in the United States and co-manages the United States Medical Licensing Examination with the National Board of Examiners. Dr. Chaudhry was an assistant dean and chair of medicine at the New York Institute of Technology, College of Osteopathic Medicine, and spent 14 years with the United States Air Force Reserve, rising to the rank of major. Thank you, Dr. Chaudhry, for joining us today.
Thank you very much, Gaurav. Appreciate that. Let me share my screen and begin. First of all, I apologize if there's some background noise, but I'm grateful for this opportunity to speak to you all about a very timely topic, and I'm particularly pleased to follow Dr. McCance's presentation to share the perspective of the state licensing boards. As Gaurav mentioned, I have a background in academic medicine. I served as a DIO, department chair, assistant dean. I also have a background in public health, having been a health commissioner in Long Island, New York, during the last pandemic, during the H1N1 pandemic. So I have a particular sensitivity and understanding towards what's currently happening with COVID-19. Just by way of background, not everyone is familiar with the Federation of State Medical Boards. We are the umbrella organization, a nonprofit of all of the nation's state and territorial medical boards that Dr. McCance referenced. We were founded in 1912, but actually our origins date to the 1800s, when there were two organizations called the National Confederation and an American Confederation that merged in 1912 to create the Federation of State Medical Boards. These were put together by the state boards themselves to provide a forum for the exchange of best practices, exchange ideas, provide a forum for education, and certainly back then, but even more important now, to share information, data about physicians who are licensed to practice medicine. State medical boards, as Dr. McCance correctly pointed out, their primary mission and purpose is to protect the public, and they do that through medical practice acts and through state statutes that are put together at every state and territory. There are more than 1 million licensed physicians, MDs and DOs in the United States, and roughly 120,000, 130,000 physician assistants. The state medical boards license the physicians and the PAs and certain other healthcare practitioners, but we have colleagues in nursing and pharmacy who do that as well. We again serve state boards. Though we don't have the power to tell a state board what to do, we respect the 10th Amendment and the rights of the states to act as they prefer for their own needs. We recognize that the FSMB has a significant pulpit from which we speak. One good example of nudging the state boards towards alignment, as one example, is there was a time not too long ago, some decades ago, when every state and territory had its own licensing examination. It's one of the reasons the state boards still, some of them retain the name of a licensing examining board. That is no longer the case. There are essentially two national licensing examinations, the USMLE, the United States Medical Licensing Examination, of which the FSMB is a co-manager, and the COMLEX examination for osteopathic physicians. Both of these examinations are accepted by all 50 states. We no longer have state-specific examinations. But in other ways, the other role that we have is to study issues and create policy documents and guidance. And whenever we do that at the FSMB, we do that very thoughtfully and carefully, because many a times our recommendations become state law, either verbatim or in part, or not at all. It's entirely up to the state boards, but we are fairly careful in every policy and guidance we issue, every comma, every semicolon that we issue. In 2018, just 2 years ago, the FSMB issued what became the largest policy document we had ever issued in the history of our organization, dating back to 1912. It was a policy on physician wellness and burnout. And I will be honest with you, when the issue first came before us in 2016 as to whether or not we should study it and how should we study it, there was some concern on the part of some of our board members about, is this really an issue for us at the FSMB? Because physician issues are typically those that are addressed by the American Medical Association, the American Osteopathic Association, the Council of Medical Specialty Societies, and others. The focus typically of our state boards are on the public. But it didn't take long for us to recognize that physician health is very closely tied to patient health, and wellness of physicians assures wellness of patients. And one of the individuals who made that argument forcefully and positively was Dr. Art Hengerer, who at the time was not only chair of the New York Board of Professional Misconduct, but also chair of the FSMB Board of Directors. So that started in 2016. We had 2 years of analysis. We thought we could do it in a year, but as Dr. McCance alluded to, this is not a straightforward issue. There are many moving parts to it. So it took us 2 years, but in the end, we put together a document that we feel has been very helpful to state boards and other stakeholders. There are 35 recommendations in it, but even before we started the process, the goals of the recommendation were to encourage physicians to seek help early when they needed it, whether for a physical condition or a mental or wellness condition. We also wanted to do what we could to remove the stigma that is associated with acknowledging a need for help. We recognize that physicians are not superhuman. They have every right to be able to see practitioners for their own wellness. And that's something that we forget. And I've told other audiences, we sometimes in medicine joke that physicians make the worst patients. It's actually not a funny matter if you think about it, because physicians have every right to be seen and taken care of for physical and mental health needs. So one of our goals was to change the perception of the medical board as being punitive. We recognize that when a physician gets a call from a state licensing board, most people don't get a warm and fuzzy feeling, because typically, more often than not, it's associated with learning more about a complaint that a board has received. But not every complaint leads to discipline. There is due process. We do try to understand the situation. Other goals of the recommendations were to promote an understanding of the duty to report to enable earlier prevention. And again, this isn't about ratting on another colleague, it's about helping another colleague. The profession of medicine works best when colleagues work together, not only within the same profession, in this case medicine, but also across other professions as well. Another goal was to support public protection work of the state medical boards and raise awareness of the roles of the state medical boards, and ultimately to improve the quality of care to patients. Our very first recommendation, again, this is after 2 years of thoughtful study with a lot of stakeholders, not just state medical boards, but members representing the profession, input from stakeholders, psychologists, psychiatrists, addiction specialists. We had representation on a number of points with representatives of SAMHSA, CDC, and others. Our very first recommendation at the FSMB as part of this document was to ask boards to evaluate whether it was truly necessary to include probing questions about a physician applicant's mental health, addiction, or substance use. And this is important because not every state does that. I'm actually an internist by training, but I'm licensed in the state of New York. New York does not ask that question for initial licensure or for renewal, and several states don't. But we know, and we learned in this process, that there were states who were asking those kinds of questions, and Dr. McCance is correct. But as part of our process and this report, more than half of all state medical boards have since 2018 discussed physician wellness and or reviewed our policy, and a number of states have revised or removed probing mental health questions from applications. In part, they've done that because they want to be compliant with federal law, especially ADA compliance, but also because they've been asked through our efforts to ask themselves what they're seeking through those questions, and are they contributing to stigma or are they lowering the stigma? One of my best examples of what a state medical board has done to address this issue is the North Carolina Medical Board, which in January of 2018, several months before our policy was issued, decided to completely change their licensure application questions and actually remove the question, but instead make it an attestation that anyone applying for a license in the state of North Carolina would acknowledge and attest that they have a responsibility not only to take care of their patients, but also to take care of themselves. That was an effort by at least one state medical board to nudge physicians to seek care for themselves, to make sure that they are able to take care of themselves and their patients both. If you can see the second recommendation, it's kind of small print there, is if a state medical board does decide to ask that sort of a question, we feel very strongly that a distinction should be made between an illness and impairment. And I think Dr. McCann spoke about that as well. For example, addiction is an illness, but an impairment is a functional classification. And I think that's what really state boards are more concerned about. We're trying to move away from asking questions that ask about specific illnesses. That's something that the physician should deal with their own provider. Our efforts in this space of clinician wellness, we have recognized is not something that we can continue to address by ourselves or alone. And so that's one of the reasons we have partnered with a number of the organizations that are shown in this slide. Chief among them, I would say, is the National Academy of Medicine. The FSMB is a supporter. We provided funding for the Action Collaborative on Clinician Wellness. And actually the chair of our FSMB work group on physician burnout and wellness serves on the Action Collaborative and has been an important partner in better understanding what the medical community and public health and what the public understand about physician wellness, clinician wellness, and what can be done about it so that they can bring that back to us at the FSMB. So it's really been a two-way benefit for the FSMB to partner in this way with the National Academy of Medicine. But there are other organizations that are listed with whom we have been working, including the AMA, including the AOA, and many federal agencies that are not listed there that have been very helpful in raising our awareness, such as SAMHSA. Now, shifting gears a little bit to talk about states' response to COVID-19, which is also related to this issue of clinician wellness. I'm not sure how many in the audience know about this or not, but all 50 states and the territories, shortly after Secretary Azar and the president declared a national emergency, all of the states and all the territories declared a similar public health emergency for their jurisdictions as well. Very shortly thereafter, the governors of these states and territories worked with the state medical boards to modify the licensure laws. 45 states modified their medical licensure requirements and renewals to enable out-of-state healthcare practitioners to practice across state lines and deliver care in person. 42 states of that 45 modified their telehealth requirements to facilitate increased licensure portability and deliver access to care. This in part enabled physicians, when New York was the epicenter, for example, to travel across the country to help out as best they could. The FSMB played a role in helping make sure that credentials were reviewed to make sure that those who were volunteering to help truly were doctors and nurses and so forth. And we worked with our colleagues in nursing and pharmacy to do that. 31 states modified their CME requirements, including exemptions, deferrals, or reductions in hour requirements. We also have something called the Interstate Medical Licensure Compact, which some of you may be familiar with. It was put together and implemented 3 years ago. 29 states, including the District of Columbia and Guam, are part of that compact. Essentially, with the compact, the participating states have agreed to 9 criteria that if a physician meets those 9 criteria, they can get licensed instantly. And when I say instantly, I mean right away. It's as simple as a physician checking off which state they'd like to be licensed in. And if they meet the 9 criteria, they should be able to get that license. It's sort of a TSA pre-check for licensure. According to FSMB data, 80% of the nation's physicians should be eligible if they wanted to get multiple licenses through that pathway. The other thing we did was partner with our other organizations in the House of Medicine, specifically with those organizations involved in the licensure, certification, accreditation, and assessment of physicians. This is a grouping called the Coalition for Physician Accountability. And early on in the pandemic, April 9th to be specific, the FSMB partnered with leaders from the AMA, the AOA, the Council of Medical Specialty Societies, the Association of American Medical Colleges, the American Association of Colleges of Osteopathic Medicine, ACCME, ACGME, ECFMG, the Liaison Commission of Medical Education, the National Board of Medical Examiners, and the National Board of Osteopathic Medical Examiners to issue an important consensus statement, which I'm summarizing in this slide. We supported strengthened efforts that must be in place to safeguard the public, but we also felt it was important to protect our nation's healthcare workers during the COVID-19 pandemic so they remain able to meet the public's needs. And specifically, we did call out the need for adequate personal protective equipment, for example, which is still sadly an issue today. The other thing, just finishing up, is supporting federal legislation. The FSMB has supported the Dr. Lorna Breen Healthcare Provider Protection Act, as well as the Coronavirus Healthcare Worker Wellness Act of 2020. Both of these pieces of legislation have bipartisan support in Congress, and they seek to raise awareness of healthcare practitioners and workers who have stress, clinician burnout, to raise awareness and to create resources so that that situation can be addressed. And we didn't just sign off on support of this. We actually, just 2 weeks ago, our FSMB's board of directors participated in virtual Capitol Hill visits to urge our members of Congress, both in the House and the Senate, to support this legislation. This is a snapshot from our Zoom meeting with Senator Bill Cassidy, a Republican of Louisiana, just as one example. Let me end there. I'm delighted again to be a part of this conversation and discussion, and look forward to questions and further discussion.
Thank you very much, Dr. Chaudhry. We appreciate your advocacy. For our next speaker, I'd like to welcome Dr. Christine Moutier, who serves as the Chief Medical Officer for the American Foundation for Suicide Prevention. She co-anchored CNN's Emmy Award-winning Finding Hope Suicide Prevention Town Hall with Anderson Cooper. Dr. Moutier has been a practicing psychiatrist and dean in the UCSD Medical School. Thank you, Dr. Moutier, for joining us today.
Thank you so much for including me in this important session. And I'll just start by, let's see, if somebody is going to manage my slides, that would be fine. If not, I can share my screen. And I'll just start by introducing myself and my organization a little bit more. I work for the American Foundation for Suicide Prevention, which is the leading nonprofit, we say, fighting suicide at a public health level nationally in the US. We're the leading private funder of all suicide prevention related research. And we have a grassroots community across all 50 states of tens of thousands of people who have been personally touched by suicide. In the beginning, mostly through loss, increasingly now as stigma is reducing with our own, what we call lived experience, which is a very important voice. And I think we all know that the readiness for change in our nation related to mental health and suicide prevention, access to care, knowledge about how to turn open attitudes into a deeper mental health literacy has been really changing quite dramatically of recent. And I also want to let you know that at AFSP, from the beginning of our organization in the 1980s, we have had a longstanding interest and commitment to physician suicide prevention, as well as all healthcare professional mental health. And that is actually how I got my start with an interest. I am a psychiatrist, but interestingly, my interest in suicide prevention started more related to the experiences of myself and my colleagues in the field of medicine, and again, more broadly, nursing and other fields related to mental health experiences as human beings, but the barriers and the cultural stigma. And so a thread through my entire career has been devoted to that. So I am very deeply grateful for the effort of the National Academy of Medicine, and am also very encouraged that for decades, there was not a readiness to embrace change and a need to look at the data and look at evidence-based solutions. And of course, we know that we're in a different era now where there is a readiness. And so a thank you to SAMHSA, to FSMB, to the ACGME, and many other organizations who were part of that really dramatic sort of readiness for change that has taken place over more recent years. So in the next few minutes, I'll be discussing a little bit about stigma and the continued barriers for physicians and other healthcare professionals to take care of our mental health adequately. We've already heard a little bit about that. I will focus a little bit of my time on just a broad view of institutional strategies that either have evidence or show promise in terms of solutions in these regards. And I will also take a moment and highlight the Dr. Lorna Breen Healthcare Provider Protection Act, which Dr. Chaudhry has just mentioned as well. Next slide. So to start, just a bit of an anecdote. Prior to 2013, when I came full-time to work at AFSP, I had spent my whole professional career at UC San Diego, eventually for the 10 years before I came to AFSP as a dean for medical education and student affairs in the School of Medicine. And what had happened in our community, I say our, but really now their community at UCSD, like in many academic medical institutions, there had been a number of losses of physicians and other health professional staff and faculty and trainees to suicide. At UCSD, we reached a readiness, again, like we see happen in the field of suicide prevention, to address the issues, to really understand better how the environment impacts an individual's risk for deterioration in mental health, and additionally, for suicide risk. And myself and my mentor, Sid Zissek, were put in charge of developing and launching a strategy institutionally to try to optimize mental health of all staff and trainees on the medical side, and eventually that extended to the nursing side. And actually now the program is for all staff and trainees at UCSD Health Sciences. That program launched in 2008, so it's been ongoing for 12 years. And I just want to tell you that at the center of that program is not only a very robust educational campaign, but a way for any individual who is suffering in silence to begin the process anonymously, to dialogue with counselors and work through their own internal barriers. And so prior to 2008, there had been 13 faculty physicians who had died by suicide over the 15 years before the launch of this program. And since the 12 years that it has been ongoing, there has been one suicide. And that is just an anecdote, but it is to say that these efforts can be very fruitful. Next slide. Now, backing up in time a little bit, what we know is that this is not a new topic. This goes back decades and decades, and just one data point is that in 2003, the AMA did a beautiful job of doing an incredible sort of analysis of the issues. And I want to highlight that at that time, they really said very clearly that barriers to treatment included these issues of discrimination in licensing, hospital privileging, and advancement. Next slide. Next slide, please. Okay, and let's go ahead. Next slide. So we've known for a long time that barriers to our own mental health care as health practitioners, and again, I really want to extend this beyond just physicians. We are talking about all health disciplines where there are various different ways that our own sense of self-identity, as well as the actual structural mechanisms around us, have kept us from feeling that we can seek care or even speak to a colleague that we're worried about. There has been so much confusion about what is reportable and what isn't. I've heard medical educators say that they've been afraid to ask a trainee about how they're doing because if they uncover a significant mental health condition or suicidal thoughts, that it would mean that they would have to do something beyond just supporting that individual. So, and that is incorrect, but there is still a layer of confusion that I believe comes from a time when we did not understand that mental health is an issue of health, like every aspect of human health, that there should be no equating of impairment with any health condition unless that is the case. And that is true for mental health as it is for physical health. Next slide. I'll just point out what wasn't working about the system in place, and you've heard from Dr. Chaudhry that the state medical boards are in fact changing their practices in terms of the inquiry about mental health on the licensing forms. That is an ongoing and very dynamic process of change that's happening right now. But as it has been, as exemplified by this study, now it's a convenient sample, but it's over 2,000 female physicians, and they were asked about, since the time they finished medical school, who among them had thought that they may have probably met criteria for a mental health condition, may or may not have had it formally diagnosed, and who thought they had met criteria for a mental health condition, but had not sought treatment. It was 2/3 of this sample size, again, convenience, of 2,000 female physicians. And those were the reasons they gave for not ever kind of seeking a more formal evaluation. Very notably and importantly, of those who had sought mental health treatment, only 6% had disclosed it honestly on the licensing application. And so we had a system that kept everybody sort of on lockdown in silence, and those who had found their way to treatment not actually answering the question terribly honestly in most instances. Next slide. The other layer that I really want to highlight with regard to stigma is not just this sort of cultural belief, ignorance linked up with a time when we did not have neuroscience to inform us. We did not have psychological studies and cognitive science to help us understand that, again, these are issues of human health. But there is also a layer that I call self-stigma that has to do with our very deep human response when we are suffering and not feeling our best. That regardless probably of how well informed we are or all of the advances we are and will continue to make with regard to the broader culture around us, that there's a layer of human instinct that will likely continue to view it, to want to withdraw and see it as unsafe to speak up. Regardless, again, of any perfect change around us, which we must strive for. So go ahead and advance twice. I have some highlights here. So just highlighting in one study of medical students, but this has been replicated across the training spectrum for medicine, that when students are not depressed, they say that the majority of them do not think that telling a counselor would be risky if they were to become depressed. But in that same cohort, if the student was depressed, more than half of them thought that it would be risky. And similarly, as regard to the statement, if I were depressed, I would seek treatment. If you're not depressed, the vast majority said, yes, of course I would. But for those who were endorsing PHQ-9 symptoms of depression, less than half of them said that they would. So there's this layer that, now this could come from external, but speaking from my own experience in this area, and advising and treating hundreds of physicians, as well as a psychiatrist and as a dean, there is this layer that is very intermingled between the external and the internal human instincts we have. Next slide. And I say that because any solution that we come up with must account for the fact that when people are suffering and becoming more at risk, they will need additional mechanisms of safety. They will need a layer of support and a sense of ongoing facilitation for them to be able to get the help that they need. Next slide. So just very briefly, without a lot of time to go into this, there are a number of institutional programs, interventions, and strategies that are, I'm thrilled to say, are going on at local levels all around our country. And I've put them into just some various categories. Some of them are really geared towards a very important thing that helps people to connect and process the distress and conflict that we all can feel as physicians, health practitioners, and human beings. And just that process of connecting with our peers and having a facilitated discussion to process. This isn't treatment. This is these types of things, process groups, Schwartz rounds, et cetera. Educational efforts, of course, are incredibly important. And some of these educational efforts are not just stigma reducing, but actually help build skills with regard to resiliency and mindfulness practices. There are also a number of usually multi-pronged programs that really aim to reduce barriers to changing culture, barriers to leadership taking action, and barriers to accessing mental health care for those practitioners who need that. And employee groups and initiatives are also a very important piece to this. A lot of this is being driven in a way by the grassroots. Next slide. And so there are another way to frame these actionable strategies is to look at them this way, that we've talked about education, and education can cover education about human mental health, health practitioner mental health, and the ramifications of those symptoms of mental health distress that are not only distressing to the individual's family and community, but can impact patient care as well. Now, that's not to say that, that there is an automatic assumption of impairment. That's not the case at all. We have such an enormous reserve, all of us, that we can be suffering, we can be having changes to our empathy and still be delivering very competent care, but it may not be optimal at that point. There needs to be education about suicide prevention, stigma reduction, and resilience building skills, as I mentioned earlier. The interventions, as I see them, are much more specific and evidence-based. So these are things like the study by Dr. Srijan Sen and his group that found that an exposure to online CBT for 4 online sessions before starting medical internship protected those interns during their internship, who then had about half of the incidents of suicidal ideation compared to the intern cohort that was exposed to a control version and not CBT. So to me, that is something that is scalable and is protective and has been demonstrated not just as a treatment, but now even as a preventive modality. The interactive screening program, the ISP, is a program that my organization had developed before I came to AFSP, and actually serves as the core root of the UCSD HERE program, which is the way for people to seek care and dialogue anonymously, as I mentioned. So the ISP is now in about 35 different medical institutions and medical schools. Multi-pronged programs are very important and cover the whole spectrum from, humanism in medicine, art, the many ways that we can connect and continue to feel the sense of meaning in our work. Policy changes are very important. And Dr. Chaudhry, I appreciated what you said in terms of the FSMB's incredible report on physician wellness that is asking institutions and state medical boards to take a look at their current policies and practices and to make those changes that are necessary, because many of them are in a way sort of hangovers from the past where we did not have the knowledge that we have now and the science to inform our work. Creating a culture of wellness. And I will say that personal storytelling and the, careful use of disclosure can be a very powerful way to model the fact that we all have mental health to take care of, and that there are many physicians who are taking care of their mental health long before they ever reach any issue of discipline, but that ways to proactively take care of our mental health is very important to have just narrative storytelling around that. While it might seem separate, policies that address toxic behaviors in the healthcare environment are a critical part to this entire strategy around wellness, because there's nothing like an abusive behavior that goes unchecked from the observation of the rest of the team to give a strong signal that this is not a safe place where I can out myself as having human needs. And advocacy has a place as well. Next slide. And so I'm going to just breeze through these because we had, again, Dr. Chaudhry himself explaining to us about the FSMB's wonderful report where they outlined these key strategies that have been recommended to all of the state medical boards. Next slide. And go ahead to the next slide. So again, and Dr. McCance-Katz also covered this, that there is recommended language as put forward by the APA, the AMA, the FSMB. I wrote about this as well, many of us have, that can serve as sort of in a way a toolkit that can be used. And I will just highlight, there is an advocacy effort going on called Humans Before Heroes. That is a coalition effort of a number of organizations in the space that are looking to try to speed up the change with regard to medical licensing and as well as hospital privileging. And again, I will say that this is not just for physicians. This should cut across all healthcare disciplines. Next slide. And just in closing then, I'll highlight again the importance of advocacy. We are seeing more legislation being proposed. The Dr. Lorna Breen Healthcare Provider Protection Act has not passed yet. It has been introduced on both the House and the Senate side. My organization and many others are strongly supporting it. And it will, along with the SAMHSA grants that we've heard about today, afford more funding and support, as well as evaluation of these wellness programs, wellness all the way to suicide prevention. It really needs to be the full spectrum. Next slide. And I will end there. And again, thank you, and look forward to the discussion with my colleagues and to getting to some of your questions, those of you who are viewing this.
Thank you, Dr. Moutier, and I really appreciate, the strategic, tactical solutions that you've offered us. And I really want to thank all of you for really highlighting the primary, secondary, and tertiary prevention goals that we all share. I want to encourage the audience to share any questions you have in the chat. We've already received several. I think I was, most heartened by the fact that I think all three of you agree on the steps that need to occur around changes around licensing and privileging, et cetera. And so certainly that begs the question that Dr. Sinsky asked us. So if we all see the utility of this, what is preventing all of the boards from updating the wording of questions about impairment to recommendations? I'll have each of you answer that if you have a thought on that. Perhaps start with Dr. Chaudhry.
So I think we're well on our way, Gaurav, to heading in that direction where this is no longer an issue. But I think back to the slide that you or someone else had about the circle that you showed. Certainly the regulatory community has a role to play. And I think one of the comments from the chat room alluded to this. It's not just the regulators. Even if tomorrow, all of the licensing boards did everything that we would like them to do at the FSMB and Dr. Moutier and Dr. McCance-Katz would like, it wouldn't completely eliminate the issue. We still have, and I think your chat room alluded to this, we have employers, hospitals, health systems, credentialing related issues where these kinds of questions still show up. So this is a truly collaborative issue, and I'm delighted to partner with my colleagues on this panel as well as others to try to make a difference. Because the other thing I'll say is, clinician stress, anxiety, burnout is not a new issue. It's always been there. What's different is, and I think Christine alluded to this, is our recognition and understanding that there is a science behind this, number one, but number two, it's impacting patient care as well. And there are suicides and really bad cases of depression that are happening that are impairing our ability to take care of our nation, especially in the middle of a pandemic. I think all of that is heightened. And I think we all need to work together to make a difference. So I'm committed to doing what I can, and everyone should be.
Additional thoughts from our panelists on that topic?
Dr. McCance, you're on mute. Maybe I'll say something while she's getting unmuted. My observation is that it takes time for all of us to integrate new information, science, advocacy, the views of others into our current MO, our way of operating. And I think it's very encouraging that the FSMB has made a very clear and cogent statement and provided the guidance, and there's all of us supporting. I think there are local forces at play and political entities that what I see happen in the suicide prevention world, which may be a parallel here, is that we all in different ways move from a state of sort of happy with the status quo to being confronted with some new information and having to move through our own sort of learning, sometimes resistance to change. And it does happen, and it will happen. And I think all of these efforts will help facilitate and speed that up.
Dr. McCance.
So what I was just going to add to that was that that I was really very pleased with what the Federation did on physician wellness, and was really a little taken aback to get from the states that had a requirement to provide resources, federal resources, for mental health services to healthcare practitioners that had COVID-19 related mental health issues, that these practitioners would not take part in it because they were concerned about being reported to their boards. So I think this really speaks to a couple of things. One, it's going to take a long time. Even if all of the state boards were to make these changes, it's going to take time for that to translate into practitioners, healthcare organizations understanding just what that means and making appropriate changes. But I want to say one more thing that really concerns me about this particular issue, and that is when we tell healthcare practitioners that it's not okay to disclose that they're having a mental health issue, when there are costs to them in terms of their practice, their profession, if they were to reveal that they're having a mental health condition, a mental disorder, that also influences how they view having such a condition, which translates into how they communicate to their patients. And my agency is dedicated to reducing the impact of mental and substance use disorders on Americans at large. One of the things I really feel we have to do, and one of the reasons we are funding centers to educate in this area, because these kinds of issues that affect healthcare practitioners also affect our patients in the way they provide healthcare to them.
Wonderful. Thank you very much.
Gaurav, if I could,
Please.
I think Dr. McCance makes an excellent point. We also have to think about the next generation of physicians and other healthcare workers, and what can we do at the undergraduate medical nursing pharmacy level, for example, to also make a difference. I'll share with you, when I was a student, I graduated from medical school in 1991, so almost 30 years ago. I remember at our campus, we asked administration if in our student lounge, we could have a television, because it didn't have one. And the response was, you're not here to watch television, you're here to study and become a doctor. And I remember this is before Netflix, so we weren't going to watch TV series. We just wanted to watch maybe the news. If there was a war outside, we wanted to know because we were in such a bubble. Fast forward to today, my alma mater, the New York Institute of Technology's College of Osteopathic Medicine, not only has a healing path on the campus with benches and billboards with poems that are sort of motivating, but they also do something that I think is a model for other schools to consider. They actually require every freshman to have a visit with a mental health care worker. And the idea behind that was, just by making such a service available doesn't always convince people to go, because people are concerned of how they might be viewed if they sought such care, because in a small campus, people find out, students find out, faculty find out. But by requiring everyone to have at least one visit, I thought that was a brilliant way to lower the stigma early on, first year of medical school, so that there's a lifelong appreciation that if you need help, you should seek it.
Great, that's great.
Thank you very much, Dr. Chaudhry. I wanted to ask you all, given that the systems need to interact in terms of the external environment, our organizations, individuals, how would you recommend we best advocate for these changes that may need to happen at the external level, whether it be for the Lorna Breen Protection Act, whether it be for the Coronavirus Healthcare Wellness Act? How should we best advocate for these changes around licensure, wording, et cetera? I might ask each of you to advise us on that. Starting with Dr. Moutier.
Sure. I mean, I've learned so much in my time at AFSP, watching how advocacy works so effectively and beautifully. And essentially what it is, I think if we have to boil it down to a little formula, it's a combination of presenting data and science as appropriate for the occasion, along with a personal story or a way to help bring the head and the heart together so that the individual or the group of decision makers has the best chance of sort of integrating the information into their real life, again, decisions and policies and practices. And it does work. And so, at the state level, we see that when relationships are formed so that it does not have to be a hostile situation. It does not need to be. It can actually be where you get to know each other, hear both sides, and kind of work towards solutions together. And that's where advocacy can be so beautiful. But the political will of the nation has become so much clearer around the need for suicide prevention and mental health sort of resources and language and access to care. That is undeniable now. So I think it's almost like within our inner circle here, we actually need to sort of catch up in a way to the larger public attitudes.
Dr. McCance, any thoughts on this question?
Well, I'll speak to the question from the perspective of government. And advocacy, I really can't emphasize enough how important advocacy is. And so having experts in the field, such as my colleagues on this panel, such as those who are listening to these presentations, having your expertise and your experience and bringing that to not only your congressional delegations, because these things will, to a large extent, they will be done through statute. And of course, the statutes will originate in Congress for national laws, but also it's important to work with us in the executive branch. And so it's important for HHS leadership to know about these efforts and to understand the importance of these efforts. We don't have, as you know, we don't always have people that have expertise in all areas. It's not possible in leadership at our agencies, but they are always willing to listen and they are always willing to hear from experts. That at least has been my experience, both inside and outside of government. And so I think it's important to advocate to the executive branch, to the agencies that can help to implement these things, such as SAMHSA, such as CMS, such as HRSA, and to also the thing that doesn't get talked about enough is the importance of working at your state levels with your governors and with your state legislators and your medical boards. All of these things kind of have to be brought together in order for us to move forward with this.
That's great advice. Thank you very much. Dr. Chaudhry, you had mentioned this issue of the compact. One of the questions from Dr. Bernstein is, any sense on what the likelihood of universal licensure might be?
So if I could,
sure.
Dr. Agarwal, let me answer that other question first, and then I'm happy to take that one. It sounds like we're in a chorus. We need to be relentless advocates, but it goes beyond that. For the FSMB, everyone's appreciating our efforts in putting together a policy paper, but many organizations put together policy papers. So I'm going to take an opportunity here to recognize the National Academy of Medicine, who several years ago decided, it's not enough to issue a impactful paper with a lot of references and references to the science. We have to do something about it, not just let these sort of documents lie on a shelf somewhere. So that's when they created these action collaboratives. There's an action collaborative on clinician wellness, and there's another action collaborative on the opioid epidemic. The FSMB happens to be a part of both of those. And I think that's what we all need to do. We need to be actively advocating. So for me, what does that mean? That means calling up a state licensing board and saying, hey, I know it's a pandemic situation. I know you're short-staffed. I know you're working from home. Where are we on that licensure application? Because these things are not changed overnight. Because there's a bureaucracy that I think Dr. McCance is alluding to. You have to try to overcome both at the state and the federal level. And that's where all of us play an important role. So, which is a nice segue into your other question about licensure. I mentioned some of the ways in which the state medical boards have been extraordinarily flexible since the pandemic began, in ways that many didn't think was possible. I mean, to get 45 out of 50 states to agree to cross-state, practice of medicine is quite incredible. Something I could not have predicted, and I've been CEO of the FSMB since 2009. So the state boards have demonstrated a great deal of flexibility. I think a big question is what's going to happen once the pandemic is over, and it will be over. Doesn't look like it right now, but at some point all pandemics end. And what's going to happen with this loosening of these requirements? So I think this is an opportunity for those who are utilizing telemedicine, for instance, to continue to do the studies, the science, if you will, to demonstrate that there are more benefits than harms. We have seen complaints at the state medical board level. I've heard from my colleagues about telemedicine being used inappropriately. Telemedicine is not for everything, of course, but there have been some concerns raised. We haven't documented it yet, but I'm beginning to hear it. And that's not a reason not to enable telemedicine, but it's something we do need to sort out to convince any naysayers out there. I think in terms of licensure, the Interstate Compact has certainly been a major revolution in the way of thinking of a state licensing board. Just the notion that you could get a dozen state boards to agree on the same criteria for licensure and get now 29 states. As a result of the compact, we've had 3,000 licenses issued through that pathway because physicians saw that it was available and they could utilize it to practice medicine in any number of states that they wanted to. And a number of states like New York and Florida have had hearings to discuss about implementing it. So that's certainly one way to enable greater access to care. I think the notion of a universal license is something that addresses a constitutional issue. There's a 10th Amendment that allows states to do what they wish for those areas that are not defined in federal ways. And so the states, this goes back to pre-American times, they were colonial boards of medicine. And so when the country was formed, it seemed only natural to continue to allow the colonies, who then became states, to regulate medicine. I think looking at innovative approaches, looking at ways in which, certainly in an emergency like a pandemic, to allow sharing of information. One of the things FSMB is doing, and Dr. McCance may be aware of this, is we're a recipient of a HRSA grant to create a repository, not only of physicians, but of nurse practitioners and other providers, so that information about these individuals can be shared among states, counties, and cities in the event of an emergency, so that those who want to help can do so rapidly and not have to do it one state at a time. So I think there's a lot of opportunities for innovation. I don't know if universal licensure is going to be top on the list, but there are many other ways that can achieve the same goals.
Thank you very much. Dr. McCance, we had a few folks ask the question of how can an organization apply for the funds you had mentioned through SAMHSA? Will there be an RFP mechanism, et cetera?
So it actually will not be a funding announcement. SAMHSA has invested quite extensively in building a national system of technical assistance and training. We have regional mental health technology transfer centers, and we will be supplementing them with money so that they can take on the process of developing these kinds of activities for healthcare practitioners in terms of health and wellness. They may seek individuals in their regions to put those trainings together. They will provide continuing medical education credit for participation, CEUs for non-physician participation, but that's how we will.
They'll be free of charge.
Oh, and my staff remind me to say that all of these things will be free of charge. So that's important. But just another thing about government, we need to get this done very, very quickly. And so in a perfect world where we had a lot of time, we might do it as a funding announcement. But because we want to get this out as soon as possible, and we expect this to be in place in January, the easiest way is for us to supplement our current grantees.
Thank you very much. We're running close to time here. Shelley Spencer asks a question that I'd love to hear your thoughts on, given especially the presentation yesterday from the AHA. If you are a mid-sized healthcare network and can only focus on one specific initiative due to resource constraints right now, what one thing would you do to provide immediate mental health relief to clinicians? Dr. Moutier, would you like to start with that? I know you have several initiatives you mentioned.
Yeah, boy, that's a tough one to narrow it down to one. I think the one that I know best and can speak to from being on the user end when I was at UCSD, and of course now I'm on the developer implementer side of it, is the interactive screening program, because it affords a consistent messaging from the leadership to the workforce that mental health is something that we all care about and will face challenges at different times. It's a way to normalize the experiences of mental health and help seeking. And because the mechanism allows the person to remain anonymous while they dialogue, I will say that at UCSD, there have been 450, probably more now, referrals of physicians into mental health care over this 12-year period. And again, I have to think that the suicide comparison that I mentioned, 13 prior, 1 since the initiation of the program, has to do with those individuals who were at high degrees of risk being able to actually find a safe way from their standpoint into care. So I would encourage anyone who wants to learn more about ISP to contact me or check out our website, afsp.org, and there's information there.
Thank you, Dr. Moutier. Dr. McCance, any thoughts on that?
I think that the fastest way to tell your staff that it is okay to seek help for mental health issues is to implement training activities, and there are innovative ways to do that. So there are courses, an hour a month, where and do it during a person's work time. That's a very powerful message that they would allow time during work for practitioners to attend informational sessions, educational sessions about attending to their mental health and wellness. I think it's really very important if you're a healthcare organization to advance this forward. Practitioners need to know that the places they work for are supportive of them getting assistance if they need it and dedicated to keeping them healthy and well.
Thank you. Dr. Chaudhry.
So, Dr. Agarwal, we've spent a lot of time talking about lowering the stigma associated with clinicians seeking care for themselves. We didn't get a chance to touch on drivers of stress beyond the obvious ones. I mean, obviously the pandemic is front and center, but we also have defensive medicine, increased bureaucracy, electronic health records. Those things have still not all sorted out in the way that they should to ease the life of practicing physicians. So I don't often get a chance to speak to health systems, hospitals, and healthcare organizations, but if I did, having been a former hospital executive, I would say to them, listen to your practitioners. They will have the best solutions because they're on the ground, they're on the front lines, and they may have the best solutions. Don't necessarily copy another system or, make sure that it makes sense for your institution.
Thank you very much. I think that's a great point to end on. I'm really grateful for you all taking the time with us today and sharing your knowledge. Thank you very much. I will turn it over to Tim.